Today, I'll talk about HIV prevention and mental health. I'll start by describing the problems we face in our efforts to end the HIV epidemic and describe the relationship between HIV prevention and mental health status. I'll describe a slice of the evidence base, focusing on our team's recent review of the literature published in the special issue of the Journal of the International AIDS Society. The special issue focused on global mental health and HIV. I'll end with opportunities for integrating the resources that global mental health and the HIV field both bring for the health and well-being of individuals managing multiple social risks. What is the situation? There's a cost to living with the adversities of social marginalization, discrimination, and poverty. They often result in disparate health outcomes. This reality is apparent in the HIV epidemic. The global community has experienced a 23% reduction in global HIV infections over the past decade. My guess is that much of the world is unaware of this news, and there's a reason for that. Countries and communities are not uniformly affected. Disparities in HIV acquisition persist, and they're aligned with social inequities. 65% of new HIV infections occur among key populations and their clients or sexual partners. Gay men and other men who have sex with men experience 25 times greater HIV risk than heterosexual men. Female sex workers experience 26 times greater risk than women in the general population. Transgender women experience 34 times greater risk than other adults. People who inject drugs have 35 times the risk than people who do not inject drugs. This signals the need for targeted, contextualized interventions. Other groups are also vulnerable and continue to experience high risk for infection, including adolescents. Girls and women in particular are at risk. Adolescent girls and women account for 24% of the new HIV infections in sub-Saharan Africa, despite constituting only 10% of the population. People with severe and persistent mental illnesses are also overrepresented among people with newly infected HIV, people newly infected with HIV. Despite the frequent disregard by the healthcare system of the sexual and relationship health among people living with a serious mental illness, in many countries, the prevalence of HIV infection is significantly higher than the general population. This is particularly true in settings without a generalized epidemic. You can see the prevalence estimates here for North America, Europe, Africa, Central and South America, and Asia. Prevalence tends to approximate, but sometimes exceed the population prevalence in settings where the HIV epidemic is generalized, that is, greater than 1% in the general population. In the United States, the prevalence estimates of HIV infection among people with serious mental illness ranges from 4 to 10-fold higher than the general population. In Uganda, however, prevalence among women with SMI is also considerably higher than HIV prevalence among women in the general population, even though Uganda does have a generalized HIV epidemic. The same determinants that drive HIV risk also increase the risk for mental health conditions or substance use. These include social exclusion, social marginalization, violence, discrimination, poverty, which lead to behaviors that can increase HIV risk, as well as behaviors that are stigmatized. Groups most at risk for HIV are often more vulnerable to mental health conditions. And note that there is a bi-directional relationship between HIV and mental health, such that HIV increases risk for mental health conditions, and mental health conditions can lead to greater vulnerability to HIV infection. A review of the mental health literature on sexual minorities reported elevated rates of depression, bipolar disorder, suicide attempts, and drug use disorders across sexual orientation and genders. Mental health conditions are also disproportionately prevalent among incarcerated people, people in prisons are at increased risk of all-cause mortality, suicide, self-harm, violence, and victimization. So these are examples of how these shared determinants of risk can interact to lead to higher rates of mental health problems, as well as vulnerability to HIV. Increasingly, HIV, mental health conditions, and substance use are considered a syndemic because of their mutually reinforcing interactions. How does having a mental health condition influence HIV risk? Let's start by considering different groups. Vulnerability to HIV and mental health conditions intersect in adolescence, a sensitive period of neuropsychological and social development during which adolescents seek greater autonomy, take more risks, and initiate sexual activity. Adolescence is also a critical period for the onset of mental disorders, and most mental disorders that are persistent in adulthood begin during adolescence. In emotionally charged situations, adolescents tend to make riskier decisions. Adolescents with mental health conditions can be vulnerable to problems like emotion regulation, which can affect decisions about sex. Adolescents and young people with mental health symptoms engage in sexual risk behaviors at higher rates than their peers. Gender also plays a role in vulnerability for both HIV and mental health conditions. Gender norms are consolidated in adolescence, and they tend to reinforce girls' unequal positions in relationships. Girls also experience a much higher incidence of depression. In fact, depressive disorders are among the leading causes of healthy years lost for adolescent girls and young women. Both of these factors can reduce ability to refuse sexual advances or to negotiate safer sex. They can also put adolescents at risk for coercive sexual experiences. Nearly 60% of adolescents living with HIV are girls. Childhood adverse experiences shape the trajectory of mental health and HIV risk also. Adults with severe mental illnesses report high rates of childhood trauma, including physical abuse, maltreatment, neglect, sexual abuse, all of which are associated with an increased risk of adult victimization. These pre-existing socio-environmental risks are consistent with the sexual and substance use behaviors that subsequently increase risk for HIV infection. These include inconsistent condom use, multiple and concurrent sexual partners who are at risk for HIV, sexual violence, financial instability, and unsafe transactional sex, as well as riskier forms of drug use. Certain psychiatric symptoms can also affect risk. We typically think about impaired judgment or disinhibition, but a recent Brazilian study of clinic attendees with mental illnesses also showed that negative symptoms, that is, blunt affect or emotional withdrawal, were associated with less perceived condom efficacy. And this could also play a role in how people negotiate sex. Discrimination and certain kinds of stigma experiences are also linked to riskier sexual behavior among women with serious mental illnesses. So let's talk about the evidence. We conducted a systematized review of the literature from 2015 to 2020 to answer these two questions. What do we know about the relationship between mental health and HIV prevention or HIV risk behaviors? And what do we know about interventions that address mental health in the context of HIV prevention? Studies were eligible for our review if they met the following criteria. They assessed correlates of HIV risk reduction activities or evaluated an HIV prevention intervention. They included some assessment of mental health conditions or cognitive processes, or they tailored an intervention for people with mental disorders. We included studies related to the use of structural and behavioral HIV risk reduction approaches, as well as biomedical prevention interventions. 57 studies met the inclusion criteria. These studies were conducted in 26 countries and 6 continents. Our study populations of interest were key populations, adolescents and young women, and people with severe mental disorders. The research covered a broad range of HIV prevention approaches, from combination prevention approaches, condom use, HIV testing and counseling, pre-exposure prophylaxis, as well as structured behavior change interventions. To summarize what we learned about the relationship between mental health and HIV risk or prevention, here are a few takeaways. Having fewer mental health symptoms was associated with more HIV testing for the most part. More depressive symptoms were associated with worse pre-exposure prophylaxis adherence, and more symptoms of depression or PTSD or severe anxiety were associated with inconsistent condom use or efficacy. But the story was sometimes mixed, and there were exceptions to the overall finding that having more symptoms of a mental health condition is associated with poorer HIV prevention outcomes or greater HIV risk. The majority of studies assessed the efficacy of behavioral interventions for HIV prevention in the category of adolescents and young women. In this group, all of the behavioral interventions in our sample showed significant positive effects on HIV prevention. These were theory-based, skills-building interventions focused on behavior change. Among these, some studies integrated mental health interventions such as behavioral therapy, emotion regulation, cognitive behavioral skills training, or cognitive processing therapy to address the needs of participants with higher prevalence of mental health conditions. For adolescents specifically, supporting parent-child communication skills and parental mental health status could improve sexual communication and thereby reduce adolescent risk behaviors. Among the behavioral intervention studies for key populations, most of the theory-based behavior change interventions also led to risk reduction. And several of these studies also integrated evidence-based mental health interventions that significantly reduced mental disorder symptoms. These included cognitive behavioral therapy, behavior activation, and affect management. There was a striking lack of new prevention research published among people with serious mental illness since 2012. We found one pilot study of an intervention that described a sexual health promotion program for people with serious mental illness. The research used a 3-session theory-based group intervention, and in the pilot study, this led to less unprotected sex. But the need for these interventions in these studies persists. A Brazilian study of risk behavior prevalence among people receiving outpatient mental health care showed that 75% reported unprotected sex, and only 9% participated in the clinic's risk reduction program. In New York State, a survey of mental health programs found that fewer mental health programs fully integrated HIV services compared to 4 years ago, despite more people with HIV in their caseloads. What did we learn works for HIV prevention and improving mental health? For interventions at the systems level, effective linkages between services such as HIV testing, mental health care, legal and other services, when delivered through a trusted community organization with a robust peer network, yielded increases in HIV prevention as well as better mental health. At the individual level, evidence-based psychological interventions integrated with structured theory-based behavior change interventions for HIV risk reduction were effective. Structural interventions also showed promise, but had gender-specific effects in some of our studies. For example, cash transfers resulted in fewer depressive symptoms for boys, but delayed sexual debut for both boys and girls in one study. Importantly, we saw that addressing broader contributors to well-being, such as interventions with a small focus on self-esteem, discrimination, minority stress, negative sexual identity, or community connectedness did not necessarily reduce symptoms of trauma, depression, and anxiety. So we have an opportunity. The global AIDS targets for 2025 call for linkage to mental health services for 90% of people living with or at high risk of HIV. They also call for a reduction in punitive laws and policies, stigma and discrimination, gender inequality, and violence, other factors that increase risk for HIV, as well as increase risk for poor mental health. Crucially, we have the opportunity to optimize social interventions that can reduce HIV risk and risk for mental health conditions. Action steps for integrated intervention include supporting gender-sensitive structural interventions for young people. This includes things like access to free schooling for girls, expanding access to family-based interventions to enhance parenting and communication skills, identify community partners and leaders for co-design, delivery, and linkage of HIV and mental health resources. Our data suggests that the best HIV prevention and mental health outcomes occur when evidence-based psychological interventions are integrated with structured HIV prevention interventions. But this is not typical of most mental health or HIV care and treatment programs globally. So we have the opportunity to utilize task shifting to train adherence counselors, peers, nurses, providers that are at hand to administer evidence-based psychological interventions. There is a growing and robust evidence base for these kinds of approaches to mental health services. We can introduce a mental health component to adherence support for pre-exposure prophylaxis. We have the opportunity to facilitate integration of sexual health promotion into mental health care settings. I want to emphasize that it's important to resume studies to promote the sexual health and HIV prevention for people with severe mental illnesses, and recognize that establishing intimacy and options for consensual sexuality can be part of recovery. Normal means that your sex, your gender, your race, and your income level will largely determine whether you have the agency and tools needed to protect yourself from disease and stay healthy. This is a quote from the 2021 UNAIDS Global AIDS Update. And what we know is that normal does not work. I'd like to acknowledge the co-authors on our systematized review for their contributions. Thank you.